Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, and welcome to the latest podcast from the Medicine Journal. I'm Albert Ferro. I'm the editor-in-chief of Medicine, and I'm very pleased to be joined today by Professor Sue Carr. She's a consultant and professor in nephrology based in Leicester. I'll let her say more about herself in a few minutes. And this is very timely because the current issue of medicine is all around renal medicine. So we thought we'd get Sue along to have a little chat about some topical issues in nephrology. So welcome, Sue.
Thank you, Albert. It's a pleasure to be here.
Great. Well, I've said a very little bit about you, who you are and where you are, but do you want to tell us a bit more about your career path?
Yes. So as you said already, I'm a consultant renal physician in Leicester and a professor of medical education. And my other role is I'm deputy medical director of the General Medical Council. So my career path so far in terms of becoming a consultant nephrologist. So I had a bit of a slow start really in my career. So I started off wanting to sort of do a hospital medicine rotation, but I wasn't successful the first time I applied for that. So I went to work in an accident emergency department in a district general hospital, which was a fantastic experience. I really enjoyed the job and passed my Part 1 MRCP and then got on a medical rotation and started my sort of career as a physician after that. And after I passed my membership, I sort of realised I'd developed a bit of a fear of renal medicine, really, because during my time as a medical student, I didn't have any placements on a renal ward, and during my early medicine training as what was then a SHO, I didn't have any placements or really see many patients with renal disease. So it became a bit of a fear that one night I'd be on call and somebody would come in with renal disease. And one day a young girl did, and my registrar was totally in control. And I just thought, I need to learn this really. So I went to do a renal SHO job in a different unit and started that job. And on my first night on call, I'll never forget, a lady came in who was a dialysis patient, and she'd had polycystic kidney disease, and she came in with pulmonary edema, and she was very, very breathless. And I sort of was starting to write up diuretics and things. And I remember saying, I won't try and, she had a real strong Geordie accent, but her saying to me, there's no point prescribing that, pet, what I need is ultrafiltration. And so I duly went off and asked my senior about that, and she was treated, etc. But that made me realise then that renal medicine is fascinating, because it's like ordinary medicine, but with other aspects, like the patient's kidneys don't work, so you have to think differently and always be alert to sort of the other dimensions of renal medicine. And then I did my clinical training kind of in reverse order. I then went on to do a research higher degree and then started my clinical training.
Okay.
So yes, a bit of a jiggedy career path, I think.
I recognise that fear of renal patients. I did an SHO job in nephrology as well. Felt completely unprepared for it. We might come back to that later, actually, in terms of education and so on. But I do recognise exactly what you're saying. And as you say, you sort of your career sort of branched into other directions as well, hasn't it? So you've got other roles now as well.
Yes, no, I have. So I guess since I became a consultant, I sort of realised fairly early on in my consultant career that I enjoyed teaching and supporting doctors who were earlier in their career, really. So I started to sort of branch out and became my first role in education was as a college tutor for medicine. And I just really realized then that, you know, that was my sort of passion alongside a clinical career. And so I've always sort of followed, I guess, a bit of a portfolio type career, really, with quite a bit of my time focused on education type activities.
Mm-hmm.
And I've sort of worked through a range of various sort of training program director activities for renal and foundation training, and then into more senior sort of education leadership roles. So I was foundation school director and then an associate dean, and before my current job, I was director for clinical education in the Leicester hospitals, which was a sort of trust side and an associate medical director level education role, which was fascinating. And I guess all that experience sort of put together basically equipped me for the role that I've done for the last 4 years as deputy medical director at the General Medical Council.
Great. Well, that's fascinating, Sue. I guess we ought to concentrate on renal medicine, since this is what the podcast is about. So just turning to that, it's obviously a very prevalent disease. CKD is very common. I think my reading says it's something like 10% of the world population has some degree of chronic kidney disease. So it's obviously very prevalent and seems to be becoming more prevalent with time. Is that the case? And why do you think that might be?
Yeah, I think that is the case, Albert. You know, chronic kidney disease is now a sort of massive health issue across the world, really. And I think, you know, quite a large part of that is due to the change in demographics of our populations around the world. Our populations are generally becoming older, and people are becoming, you know, weight and obesity is increasingly common, and we have more diabetes and hypertension. So I think that sort of, you know, that sort of aging population and increasing comorbidity is sort of driving a lot of that increase in CKD, and we need to be very mindful of that in our treatment and detection of CKD.
I'm obviously very sort of aware about the preventative side of things. You know, being a hypertension specialist, and it is really all about prevention. I mean, treatment is obviously very important, but prevention is something that we need to focus more on, I think. And how could we perhaps sort of more effectively prevent CKD? I guess we're talking about, you know, treating the risk factors, but what in practical terms, what should we be doing, do you think, to try and prevent this epidemic?
Yes, I think prevention is absolutely key here, Albert. Prevention and delaying progression, I would say. So thinking about prevention, I think there's a lot we can do. And I think, you know, starting with sort of lifestyle measures and risk factor modification, as you say. So I think identifying people who are likely to be at risk of CKD. So, you know, thinking about those older people with diabetes, people with hypertension in particular, thinking about lifestyle modification with stopping smoking, less salt in the diet, exercising more, are all absolutely critical to prevention. I mean, some factors we can't change. We can't change our age, our gender, or our ethnicity. So those risk factors remain, but we can change a lot of other things. So I think early detection is absolutely key. Opportunistic testing of blood pressure to detect, you know, hypertension when patients contact health services, dipsticking urine similarly, you know, taking these opportunities to identify people with CKD. And I think, you know, as we've said, it's increasingly common. So many of those contacts are outside of secondary care, they're in primary care. So our colleagues in primary care have a really important role in this, and so does the wider healthcare team. So, you know, everyone within that hopefully can identify and sort of intervene with these preventative measures. Because I think every time there's a contact with somebody who's at risk of CKD, we really need people to think about, well, I need to check their blood pressure, I need to give some advice here. And then, you know, it's the first step towards prevention and delaying progression, isn't it?
And it is all about team working, isn't it, as you rightly say. And I think in that respect, I mean, my personal opinion is that prevention, you do rely on lots of different professionals and also family members working together, really, isn't it?
Yeah, most definitely. You know, I think you know, doctors are a part of the healthcare team, but the whole healthcare team needs to work together on this, and it's a public health issue too, isn't it? So literally across the spectrum of healthcare, we need to encourage everyone to be CKD aware, really. And as you say, family members too. If someone, you know, patients who have renal disease are able to educate others with renal disease. And the lifestyle measures go far wider than that, don't they? That's a sort of population issue.
One thing I've found, for example, with hypertension is that because you're medicalizing a group of people that are relatively well, there's often a lot of resistance to sort of implementing lifestyle measures and changing things, going on to drugs, because they feel perfectly well and they don't yet have any latent, any obvious disease. So that can be a real issue. And that's where just seeing the specialist once every few months or whatever doesn't really cut it, because you need that reinforcement. You need other people to give the same message. You need family members on board as well, so they cut out salt in cooking and so forth. It's all of those things, isn't it?
It is. It's that spectrum of everyone getting involved, and as you say, it's a real battle with hypertension and other conditions that aren't painful or visible, that people sort of, you know, it takes a while to sort of accept that the condition's there and take action. So I think, you know, this is far wider than just CKD, isn't it? But we have a need to do this across many sort of areas of healthcare at the moment. I think it's the fundamental, it's the most important thing, really. Prevent the disease and prevent progression.
Indeed. So focusing down on CKD again, and determining who's at risk of progression of CKD. I think you mentioned to me in one of our earlier discussions that there was this tool now that you could use to try and predict that better. Is that right?
Well, yes. So most fairly recently, I mean, we're all kind of familiar at looking at EGFRs now, aren't we? But we sort of moved on now to there's a new tool called the kidney risk failure equation, risk failure, KRFE, which is just really come into practice, and it's a very useful tool, again for primary care and secondary care, because it helps actually guide really people to know what the risk of progression is. So when you use that risk factor equation, it can actually predict the risk for a person at 5 years. And I'm finding it a very useful tool in practice to be able to address that issue we were just discussing about, and helping patients decide whether they want to take medication. And it really helps shared decision making, because a lot of our patients take a lot of medicines for different conditions. And I think I'm finding that when you sort of show people the risk and say, well, you know, we've done this on the computer and here I'm showing you this on the screen, it shows that your risk of needing dialysis in 5 years is, you know, for example, 35%. That's quite a lot, isn't it? And, you know, if you have these medications, this is what it'll do to the risk. Then people can work it out, really, and they can think, well, yes, that's a risk I don't want to take. I'd like to do something to reduce that risk. So I think this is a real step forward in supporting doctors and healthcare professionals, but also patients, to be able to make those sort of risk-benefit decisions about their care and their treatment.
Sounds really good. Yeah. Now, in terms of drugs used to prevent progression and so on, we obviously know about the ACE inhibitors and angiotensin receptor blockers in type 2 diabetes. They've been around and established for a very long time now. But what is their role? Is it just confined to type 2 diabetes, or are they useful more generally, do you think?
Well, yes, they are, Albert, definitely. I mean, I think the tools we have in the sort of box for using pharmacological methods to delay progression of renal disease is using medications to reduce blood pressure. And as you say, we sort of learned that from the studies 20 years or more ago, that having a lower blood pressure slowed the rate of decline of renal disease and also lowering the proteinuria. And that was first found really in the diabetic populations. But there fairly soon after followed studies in people who not only had diabetes, but had chronic kidney disease from other causes as well. So, we now know that lowering blood pressure is good irrespective of the cause of your renal disease, as is lowering proteinuria, whether you've got diabetes or not. So, ACE inhibitors, ARBs are definitely, really important for people who don't have contraindications to them, whether they're diabetic or not. One thing just to mention is that what we do know is using both together is not a good thing. So 15, 20 years ago, I can't remember exactly how long, there was a trend for using both together, and that was shown not to be advantageous and not really to be safe due to hyperkalemia.
Sure. People have a kind of love-hate relationship with ACE inhibitors and kidney disease, don't they? Because they're always worried that they're going to make the kidney disease worse, actually. And in fact, there's been this a lot of uncertainty about whether these drugs should be continued in people who have progressive renal disease. But I think there's been some evidence on that recently as to whether ACE inhibitors, ARBs, should be discontinued or not. Could you tell us just a bit about that?
Yes, no, I can. I mean, I think, yes, as you describe, Albert, people have had concerns for a number of years or thoughts for a number of years that when you start somebody on an ACE inhibitor or an ARB, it's well known that in that initiation phase, their EGFR drops a little bit, and then it sort of starts to go up again, and you see the protective effect. So there was a sort of hypothesis that when people had more advanced CKD 4 or 5, that if you stop the ACE inhibitor, you might see that GFR sort of come up again, and it might delay the decline in EGFR in advanced chronic kidney disease. So there's been a couple of trials published recently addressing that issue. So there was a UK trial called Stop ACE, and there's been a study in the Lancet from Hong Kong recently, looking at, so the Hong Kong study looked at people with non-insulin dependent diabetes and advanced chronic kidney disease, and the Stop ACE looked at a more general population, and basically showed that stopping ACE inhibitors was not associated with any improvement in EGFR, and in fact in the Lancet study it showed an increased risk of cardiovascular and renal events. So in general, that evidence would support continuing patients on ACE inhibitors, as long as things like their potassium is safe, etc., in patients with advanced chronic kidney disease.
Well, it's good to have a bit of clarity on what to do with these drugs in patients with advanced CKD. And the message, as you say, being that these drugs should be continued in the absence of any contraindications such as hyperkalemia. So that's the ACE inhibitors, the ARBs, and there are some newer drugs around now, aren't there, which are coming into the news?
Yeah, exactly. I must say it's an exciting time to be working in chronic kidney disease, to be honest, because I say what with the risk equation, and now we've got quite a host of new medications. So SGLT2 inhibitors, I'm sure listeners and readers of the journal have heard about, but they've been found to have, in addition to their role in diabetes, a renal protective effect and a cardioprotective effect. And with respect to renal disease, now we've got 3 trials now that evidence the benefits. So there was a study, Credence study, that showed a benefit in non-incident diabetics, and we've now had DAPA-CKD study, which showed a renal protective effect in non-diabetic CKD patients. And there's another trial, EMPA-Kidney, similarly looking at a different SGLT2 inhibitor in patients with chronic kidney disease. So we've got 3, really strong pieces of evidence now that support the use of SGLT2 inhibitors in diabetic and non-diabetic people with chronic kidney disease. And it does seem like the EGFR, so for renal physicians, it's always a consideration of, how low can the GFR be before you need to sort of think about stopping these medications. Well, we seem to have from EMPA-Kidney now, EGFRs in the sort of lower 20s. So that was looked at people with EGFRs down to a level of 20, and the other studies had slightly different EGFR ranges, but we can now use these patients in people with more advanced chronic kidney disease as well. So I would say we're sort of, introducing those medications in nephrology practice now, and when we're using them, we always have to be mindful. They are medications which come with some quite significant side effects for some people. So it's really important to consider their other medications, to consider their risk factor profile. If they've had ketoacidosis, etc., if they've had foot problems. To make sure that we've considered those things and that we've informed our patients about them.
Yeah, I must say the SGLT2 inhibitors have really sort of taken off very much, in my field as well, in the cardiovascular field. They've really sort of found a very big niche there. Then there's finerenone as well, isn't there?
Yes. I say we've we've now got lots of medications now for CKD. So yes, there's finerenone. I can never say that properly as well, which is a non-steroidal mineralocorticoid receptor antagonist, and people, that's also can prevent can be renal protective. There's some evidence in patients with diabetic kidney disease, and there's some ongoing studies, I think they're called Fidelio and Figaro. So the evidence is sort of accumulating for the use of those medications too. I guess at the moment we're tending, we use the ACE inhibitors, ARBs, and then looking at SGLT2 inhibitors, and then the new MRAs. And we've got to be mindful of, as we say, things like potassium, things like other medications. And it's often a case of looking how these medications kind of fit together on an individual patient basis, and working with the patients to decide, how many medications they want to take.
Yeah, indeed.
I think we're entering a really interesting area. We can't just keep adding things to people's medication, can we? We have to sort of work with people to persuade them it's of benefit, and see how it works out for individuals in that way.
I think that's a very relevant point, Sue, and there's a lot of emphasis at the moment on polypharmacy and deprescribing, which is a priority for the NHS. So shouldn't necessarily be overloading patients with more and more medication unless there's a clear benefit for it. So that's very relevant. Perhaps I'll sort of round off this podcast with a return to one of your other roles. That's the education role and the relevance to renal medicine. And I think you highlighted in your story how you felt as a junior trainee relatively unprepared for treating patients with kidney disease. As did I, in fact. And do you think there is some work to be done there on the education side. Do you think it is taught well enough? Do we need to teach it better to our medical students, our junior doctors? What are your thoughts around education and kidney disease?
Yeah, I think it's an interesting one, isn't it? When we think about it at undergraduate level and at postgraduate training level. So I think it's clearly important for medical students and doctors to be aware of CKD in particular, because it's such a common condition across the world, really, and it affects so many people with other comorbidities. So whatever type of doctor you are, you're likely to see people with renal disease, and it's important that you're able to recognize it. So I think we need to sort of open our eyes to the fact that, you know, you can teach renal disease not just in a renal module. So, you know, it needs to be integrated into teaching around comorbidities, around you know, all those things about health inequalities, around population health. I think there's a role for making sure the message about preventing and treating chronic kidney disease is in there. I think more specialist teaching can be sort of taught in certain places, but you know, for the most relevant part for all doctors is, you know, if you're a diabetes doctor or a hypertension doctor or a urology doctor, or, you know, so you're going to see people with CKD. So being aware that you should check their blood pressure and check their U's and E's and do something is really key. So I think that generalist education, including renal education, is important. I think in terms of nephrology teaching in general, I think, yes, you know, ideally I would like far more people to experience nephrology, because it was a real gap for me. And I think it's really important that we're kind of creative with our teaching opportunities, because realistically, you know, as the number of medical students increases, etc., it's going to be hard for them all to do a renal placement. It's, you know, there's only a certain number of secondary care renal placements to do. So I think we need to be creative around, you know, providing virtual opportunities, virtual placements. As nephrologists, you know, to get on board with really creating materials that this increasing number of learners can access. And I think the other thing about nephrology placements is advertising the broader aspects of nephrology, you know, how much we do about ethics and about difficult conversations and about you know, all those more generic aspects of medicine, and sort of selling that as well. So I think, yes, you know, I would like more people to be taught about nephrology. I do accept they can't all do a rotation into a nephrology unit, so we need to use technology and newer ways of delivering that. And I think, like, as all time, you know, I think role models are really important in encouraging people to engage in our specialty. You know, so I think we've got some fantastic role models in renal medicine. So, you know, getting them to be visible and to sort of show people what an interesting specialty we have and how relevant it is across a breadth of medicine, really.
You've done a good job in that respect on this podcast, in showing how interesting it is and can be, and hopefully this podcast may play a small role in getting the message out there.
So, I mean, I hope so. I say I, you know, have many other roles, but I still love being a nephrologist, and that's why I still do it.
Oh, brilliant! It's been a real pleasure, Sue Carr. Thank you very much indeed.
Thanks, Albert.